I actually gave the similar version of this talk back in 2018 to the Department of Medicine here, prior to me joining the faculty. So a lot of these things will be kind of repeated, but at the same time, there's a different spin on it as I go through it. So I have no disclosures. So again, whenever I do a talk, usually it's been for this, for the division, it's been more of case-based, but this is a little more science. And so I deemed it necessary to kind of have objectives. So what I want to convey today is, you guys to understand, have a basic understanding of the microbiology and epidemiology of NTMs, more specifically abscessus. Okay, and we practice in Florida, so it's important that we understand what's going on here, and we also have to understand the types of the pathophysiologic conditions that they cause. So also I want to kind of discuss a little bit of some of the current understanding of both the immunological pathophysiology of these infections, especially M. abscessus, some of the pharmacotherapeutic options, and what's kind of going in the pipeline. And then, from my perspective, and the most important thing is the research. I think it's important that we understand that it's not just the clinical presentations of these patients, but as the fellows understand, it also has to do with what questions can we answer from seeing these patients, and how can we improve their outcomes in the future, whether that be from pharmacotherapeutics, whether that be from epidemiology and understanding more about where this thing is located, but then finally also the immune system and what's happening, and how our bodies are trying to combat it. So I'm starting this off with a quote. So Kevin Fennelly is a former colleague of mine at the University of Florida, and he's up at the NIH right now. He's clinical faculty and works in Ken Olivier's group in the pulmonary section at the NIH. And so Kevin's been studying NTMs now for probably about a quarter century. And so, one day he and I are having coffee outside of the Emerging Pathogens Institute, and we're talking, and I said, I've been seeing a lot of abscesses here in Florida since I got here from California, which was different from what we saw there. What's going on with that? And I said, and what do you think? And he says, let me tell you something. He quoted this. Not that I would want the choice, but if you asked me whether I would want XDR TB or Mycobacterium abscessus infection, I would pick the former. And I kind of looked at him kind of funny, and I said, Kevin, are you serious? And he says, absolutely. And then he goes on, about all these other patients that he's seeing at UF and all the problems that they're having and how many new cases he's seen. And we thought that was kind of interesting. So, but let's get into it. But before we go into what's going on and the science, I think it's important that, again, this is still kind of a clinical audience. And so deem it necessary to go through two brief cases. And these cases will show you that, there'll be some good outcomes and then some not good outcomes. So case one is a 62-year-old engineer with a history of interstitial pulmonary fibrosis, who's now status post bilateral pulmonary transplantation in January of 2017. So he had been hospitalized at Shands this entire time. Okay. In June of 2017, he had a worsening productive cough, chills, and nodules on chest X-ray. Now he has not left this room. Again, very important. So they bronched him, and his BAL demonstrated normal flora, and he was treated for aspiration pneumonia with vancomycin and cefepime for 10 days. But the productive cough continued and got worse. So they repeated the BAL, and they sent fungal and AFB along with Legionella cultures. So his past medical history, he's got interstitial pulmonary fibrosis, which was idiopathic in origin. His allergies are to sulfa. His meds are mycophenolate, tacrolimus, valganciclovir, voriconazole. His family medical history is really not contributory. Social history is originally from Atlanta, Georgia. He's a software engineer, and he's married with 2 daughters. He has no pets, travel, has only really been around the southeastern and southwestern U.S. So his hospital course is prolonged. By the time I saw him, he had been hospitalized for 8 months. He had been on and off ECMO during this time. He had adrenal insufficiency, pulmonary aspergillosis. He was chronically on the vent. And he had diaphragmatic paralysis and new status post-diaphragmatic pacemaker since March of 2017. That was probably a result of the surgery, the original surgery. So on physical exam, he was febrile at 38.7 Celsius. He was tacking away at 106. Of course, his respiratory was controlled at 16. Blood pressure was satisfactory. His vent settings, he was on pressure support, pressure of 16, PEEP of 7, FiO2 of 55%. So the generally ill-appearing man, he's got a trach. He's got dry mucosa that I could see in his mouth. He's using his accessory muscles slightly. He's got coarse breath sounds bilaterally. Sinus tachycardia, and he's got some small superficial ulcers along the mid-axillary line bilaterally. So the culture went out to the National Jewish Hospital Mycobacteriology Lab, and it grew Mycobacterium abscessus, subspecies abscessus. The HAIN probe was positive for ERM41 gene. We'll get to that later. And the RRL gene was not present, nor was the RRS gene. So the MITs, of course, were done by Broth dilution. And the sensitivity pattern was as follows. Sensitive to tigecycline, amikacin, clarithromycin, and azithromycin, and clofazimine, as well as clofazimine amikacin combination. It was intermediate to cefoxitin, imipenem-cilastatin, and right out resistant to amoxiclav, tobramycin, ciprofloxacin, doxycycline, moxifloxacin, cotrimoxazole, which is Bactrim, and linezolid. So his original regimen was clarithromycin, inhaled amikacin, not liposomal at the time, and imipenem-cilastatin. So this is why therapeutic drug monitoring is important. We obtained imipenem-cilastatin levels, and I adjusted the imipenem-cilastatin to continuous infusion while he was in the hospital, which is actually not difficult to do. You just have to have pharmacy work closely with you. So I also added amikacin IV. I switched the clarithromycin, azithromycin, and I started tigecycline Q24 and was giving him low-dose clonazepam. And the reason for the clonazepam is to quell any kind of emesis that he has. So we were considering other antibiotics such as bedaquiline and clofazimine. Unfortunately for him, he actually succumbed to the disease and ended up having a cardiopulmonary arrest and in the face of having pretty severe mycobacterial disease. And it was interesting to note that the lesions that were on that mid axillary line bilaterally were from the original surgery, and the Mycobacterium abscessus had disseminated there. So again, it had gotten into the bloodstream, and nobody thought about this until later, and he died of disseminated Mycobacterium abscessus disease. Case 2 is a 54-year-old man with history of end-stage renal disease from polycystic kidney. He'd been on peritoneal dialysis for 5 years rather. He had 2 previous PD catheter infections, one with E. coli and one with Proteus vulgaris. And in late 2016, he presented with subjective fevers, chills, and a 10-kilogram weight loss, which had occurred over a 6-month period. He noticed some induration surrounding the catheter PD site, but it was minimal, and so he didn't really think much of it. So in February of 2017, they did a biopsy of the PD catheter stoma site, and they grew Mycobacterium abscessus, subspecies abscessus. So they gave him amikacin through the peritoneal dialysis catheter, azithromycin by mouth, and cefoxitin through the PD catheter for 6 to 12 months. Now I have this boat there on the right, and that is a Genu. So it's a type of sailboat, and this is what he lives on. He sails around the Caribbean and enjoys the time with him and his wife. And he actually does peritoneal dialysis on the boat, which is impressive. Anyway, so here are his results of the Mycobacterium abscessus that was that grew out. And so he actually was admitted to Shands from the VA at my behest, so that we can actually see what was going on with his sensitivity pattern, but also to probably exchange the catheter and treat him a different way. So as you can see there, the pattern was kind of similar to the first patient, right? So it was susceptible to amikacin, azithromycin was susceptible, the cefepime and cefotaxime were resistant, the MIC to cefoxitin was intermediate, ceftriaxone, of course, resistant, cipro resistant, clarithromycin susceptible, the clofazimine was susceptible, doxy resistant, gent resistant, imipenem intermediate, kanamycin susceptible, linezolid resistant, minocycline and moxy resistant, Tiggy susceptible, and resistant even to tobramycin and Bactrim. So we kind of decided on, and I used to see my handwriting there on the right. So what we did is that, made him come into Shands from the VA, and we removed his PD catheter in January of 2018. And I talked to my nephrology colleagues, and we put him on IHD. And I think that was critical because it allowed him time to heal. And so, but again, he continued to grow the abscesses from that site. And we actually sent the specimen, piece of the pathologic specimen to our microbiologic colleagues, who ended up detecting biofilms using SEM, which is kind of cool. Anyway, so we gave him amikacin IV, azithromycin, meropenem on a continuous infusion, and tigecycline. And so again, we gave him low-dose clonazepam, and I treated him for a 12 to 18-month course. So not only is he improving now after replacement of the PD catheter, but we actually bridged him to get a solid organ transplant for his kidney. And he has been, from what my colleagues tell me at UF and the VA, very successful. So this, he survived the M. abscessus infection. So are there any questions thus far? Okay. So non-tuberculous mycobacteria. So everybody throws NTM around. So what are they? So, these are pathogens that are millions and millions of years old, almost the order of 1 billion years. And they're really environmental pathogens, right? So, and they're ubiquitous in the environment. And, several 100,000 years ago, a group of them kind of started to invade the bodies of animals. And this grew into the two groups we know of as Mycobacterium leprae and then the Mycobacterium tuberculosis complex group. However, the rest of them stayed in the soil and the water, as their kin had in the past. So we can break them down into two real big groups: rapidly growing mycobacteria and slow growing mycobacteria. So, rapidly growing mycobacteria, they really grow around 3 to 7 days, and that has to do with their generation time of, undergoing, mitosis anywhere from, 6 to 12 to 18 hours. And the organisms that are in there are the Mycobacterium abscessus complex, Mycobacterium chelonae, and fortuitum. Slow-growing mycobacteria, cultures that grow anywhere from 2 to 8 weeks, and that's because their mitosis time, their time to mitosis rather, is anywhere from 24 to 60 hours, and that's why it takes them so long to grow. And with them, the Mycobacterium avium complex, which there are 6 big organisms that are in that complex. Mycobacterium xenopii, which we see a lot more in the northern latitudes of this hemisphere. Mycobacterium haemophilum, marinum, kansasii, and even gordoni, which for the most part is a contaminant that we see in the lab, but can infect certain HIV patients. So this is a map from Becky Prevost's group at the NIH, and this was in 2012. It shows that that where the incidence of cases were documented based on CMS. There are sporadic cases that are in California, some that are in Louisiana, and some of the major metropolitan centers in the Northeast. But the real bulk of the cases are in Florida and Hawaii. And that's very interesting. So, but again, like I said, mycobacteria, rapidly growing mycobacteria, the main subspecies of abscessus are abscessus itself, Bollettii, and Massiliensis. So again, they're commensal organisms of soil and water, like I've seen, and they're commonly found in water pipes and water sources. So all individuals are exposed during their lifetime, right? Here in Florida, and the reason, has to do with municipal water supplies, and we'll talk about that in a minute. But the disease usually occurs in patients who have intrinsic pulmonary disease, those who are severely immunocompromised, those who have prior cavitary disease such as tuberculosis or a bad Staph aureus pneumonia. And there's also the selected body phenotype. And what do I mean by that? So we're talking about this quote unquote Lady Windermere syndrome, which we see most often occurs in Caucasians and East Asians, and they're usually women, and they're usually thin, and they're usually in their 50s to 60s to 70s. Now, rarely do the other rapidly growing mycobacteria cause pulmonary infection, but they can occur. But abscessus is the king in terms of it causing pulmonary infection. There's also what can occur in terms of integumental puncture, which is usually self-resolving. But in these groups that are above, you will definitely see patients have long-standing infection, and they require antibiotic therapy because they really can't clear the infection. So, let's go, before we go into that, we'll talk briefly about why this is happening. So, in the water supply here in Florida, a lot of municipalities in the state, where they get their water from, it's usually chlorine gas that is added as the agent to make the water potable, right? And so what does that do? So that decreases the other bacteria that mycobacteria usually have to compete with for resources. But they also, eliminate organisms which are predators of mycobacteria, right? Things like amoeba and dictyostelium and these things. And so what happens is that, the mycobacteria survive, and then they bloom in the water supply. That's usually why we see it. But they like to, if they're not making a biofilm, they like to infect, eukaryotic cells. That includes us. And so what happens is that once phagocytosis occurs, whether that be dendritic cell, macrophage lineage cells, and whatnot, they go into what's called a smooth phenotype. So, this prevents the phagolysosome from actually, maturing, and, the different mechanisms to pour acid into there to dissolve the organism, and other proteolysins. And again, usually it's one bacteria that's in there. And as you can see on the scanning electron micrograph, this ETZ, this electron translucent zone, this shows that the organism is kind of, taking control of the phagolysosome and is able to do what it wants in there. And it kind of forms this almost like a capsule there. And again, this prevents the phagolysosome from doing its job. Whether that's, related to cyclic AMP and other mechanisms, there's some hypotheses to that, but hasn't really been fleshed out. But again, once the macrophage has been overtaken, there's less apoptosis of those cells and direct destruction of them by the lymphocytes, including cytotoxic T cells, to do their job to kill these infected cells, and thus they become a factory for these organisms to reproduce. And so when they want to start to reproduce, and the coast is quote unquote clear, they undergo a rough phenotype. And so what happens is that they break the phagolysosome. They start to create this phagocytic cup, which you can demonstrate here by these arrows from Rue et al. In 2016. And you can see here that they start to pop out, bud off, or quote unquote, of the macrophage. And then there's rapid, active replication. And so then there's multiple daughter cells, and then they kind of eventually lyse the macrophage. Or what they'll do is they'll actually cause the macrophage to undergo apoptosis or pheroptosis, and then once in a while you'll actually see the organisms coalescing together, and that's called courting, which is notorious in Mycobacterium tuberculosis complex, but can be seen with some non-tuberculous mycobacteria, and this is the case. So the microbiology, we're going to continue with this. So again, they can persist in the environment inside of amoeba and their kin, both in trophozoites and in cysts. And so again, they can go from smooth to rough phenotype. And once it's in the rough phenotype, it's a pro-inflammatory kind of thing. And there's this gene called SX4, which is similar to ESX1 in TB. And again, this causes the fatal lysosome to rupture. It's a type 7 secretion system. And again, some gram-positives have this as well as mycobacteria, but this also causes increase in virulence. And both MAC and abscessus can do this. And this again causes more organism to be released from these cells, and thus to seek out other macrophage lineage cells, and thus causes other end cells to become infected. So as I kind of said here, how do you get this? So again, it's waterborne for the most part, and it's all in the municipal water system. Now you might, the fellows will discuss with me, well, Anthony, the patient also, has well water. Well, well water, turns out, doesn't have a lot of mycobacteria in it. And the reason is because, there's a lot more of these organisms to compete with for resources, and the predators are in there too. So it really, these things really grow in that environment, but they don't grow as much as in the municipal water. So anytime you can aerosolize water, we're talking about showers, hot tubs, ice machines, yes, even ice machines, and of course soil. So people who garden, they not only are they exposed to the soil, but they're also spraying water usually, and whether it's a mist on the nozzle on their hose, sprayer on their hose, people get infected, and so that's kind of a problem. Now, because of the fact that they really have lipid-rich membranes, do they form these liposomes, and thus is there increased aerosolization? That's probably true, because they can kind of hang out inside of a droplet of water in a liposome, and then infect people that way, and then it just gets in. It's easier. So what happens when it gets inside of you? Well, this is TB here, but more than likely it's kind of similar. So one of the first things it does is it starts to set off certain signals that downregulate cilia production of epithelial cells lining the trachea and lining bronchi and bronchioles. And so there's infection of different cells as well, not just interstitial macrophages, but also dendritic cells, and interestingly enough, goblet cells. And so again, less mucus is produced, and so you can't cough these things up. And this is all in direct response for the organism to survive and kind of hang out. Once it gets inside the alveolar space, the gambit is on. Again, they can live inside of surfactant, as you can see here. They can live inside of type 1 and type 2 pneumocytes and alveolar macrophages. But what's interesting is that they can also live inside of interstitial macrophages. And this is one of the things that, when we discuss therapeutics and we talk about inhaled liposomal amikacin, why I think that there is a problem with that is because we don't know if these liposomes get inside of interstitial macrophages. And if that is a harbinger of for the pathophysiology of the organism, well, then that's not doing much. So you also have to administer other antibiotics to penetrate those cells. Now, one of the cells that's here, and it's not labeled, is very interesting. And that is an innate T cell. And you're probably saying to yourself, what? Well, we'll discuss that later. But I believe, and this is my hypothesis, is that it is critical for the management and and elimination of this organism in the lung. And I think that it's a big player, but really has not been shown that yet because no one has done the studies. So diagnostics usually with the patients, the best labs are National Jewish Hospital in Denver and the University of Texas at Tyler. Both have mycobacteriology labs. Both are staffed with some of the best and most knowledgeable physicians and scientists in the nation. That's what they study. Interestingly enough, it's a BSL-2 agent. So you can do this on a regular standard bench. You don't need TB precautions. Unfortunately, here in Florida, all these samples that turn out to be mycobacterial, if they end up going to the state anyway, and once TB is ruled out, then they'll send it off to either the CDC or one of these two hospitals, as I mentioned here, for identification. Now, what's interesting is that in July of 2017, you can actually, the FDA actually said that you could do mass spectrometry. Now, that hasn't been rolled out nationwide because mass spec can be expensive, but it can differentiate all the different species of mycobacteria, and that's kind of cool. So again, as we go to more of a molecular, biologic approach to infectious diseases, mass spec could come into play a lot more. But also there's a company out of Germany called HAIN, and they've been making line probe assays for numerous years. So several years, and they've always been interested in mycobacteria, and they've been working on a line probe assay for TB for years, which detects rifamycin and INH resistance, besides telling you what the organism is. And it also works for some other antibiotics in TB. But now they've actually been doing this for NTMs as well, and they're using this throughout Europe and in some facilities in the United States, including the National Jewish Hospital. So MAC, again, it can identify the three main species of MAC, even though there are 6 or more, Chelonia and Fortuitum, and also will tell you if, not only is it Mycobacterium abscessus, but the 3 different subspecies, abscessus, Bollettii, and Mesiliense. And then we'll give you the different genes of resistance in these organisms, where ERM is inducible macrolide resistance, RRL is frank macrolide resistance, and RRS is frank aminoglycoside resistance. And this is what it looks like. This is from my lab. We actually did this on some specimens from Shands back in 2017, 2018. And you can see here that each of these indications kind of tells you what the different genes are that are there, and will tell you what the organism is, basically. And then you'll see here that there's ERM41 detection, RRL and RRS, which again will tell you whether or not there's resistance to some of these other antibiotics. Any questions?
Yeah, lecture.
Hello?
None so far.
Excellent. So how do we get sensitivities to this? Well, you really can't grow these organisms in a Kirby-Bauer plate or other methods, or e-tests and whatnot. It's really done by microbroth dilution. So what's that? So you take a 96 well plate and you put the organism on a culture media, and then what you do is you slowly dilute the drug there, and the mycobacterial culture is the same concentration throughout the plate. And what this tells you is that this tells you where the MIC could be, and that's usually noted where there's a clearing in that plate. However, if you can think about this, this is truly subjective and is based on the laboratory technologist's experience and also a little bit of luck. And sometimes there are disagreements. And this is a very subjective method. So if you see that a susceptibility to a drug is intermediate, it might very well be resistant. And so again, that's why we really need a better methodology to how we come up with these MICs in these organisms. So what are our therapeutic options for Mycobacterium abscessus? So usually the bedrock therapy is a macrolide, IV amikacin usually, and beta-lactams. Cefoxitin or imicilastatin is used. However, I can tell you that meropenem works just as well as imipenem-cilastatin and can be given much more easily continuous infusion outpatient despite what some of our suppliers say. And also, it's much more stable from a biochemistry point of view. And there's also some data to suggest out of Robert Bonomo's group from Case Western using dual beta-lactams. And some studies have shown that imipenem-cilastatin and ceftazidime or meropenem plus ceftaroline have been used, in combination with some of these patients, and have generated some success. And I can tell you that I've done this several times now. I still have some patients that I'm waiting on results to see because they have such long-term infections. But still, so there's a period of time where in MAC therapy you usually do 2 to 4 months, see how they do, and then move forward. Well, with this, there's an induction phase of about 8 to 16 weeks. But I can tell you that I've had patients be on these antibiotics continuously for almost 2 years, depending on the location of the infection. Now, Mesiliense really has a partially truncated ERM41 gene, so you can use macrolides in them. Inhaled amikacin is something that people have used, including liposomal amikacin inhaled. But again, like I said, I don't know if that really penetrates the the interstitial macrophages, the pulmonary macrophages, and thus that could be an issue. Fluoroquinolones and sulfa straight up are either intermediate, but everyone I've ever seen has been really resistant. Clofazimine is a drug that we're using more and more in these groups. Lincosides like linezolid are used. Tigecycline, which I use often, unless it's a bloodstream infection. And I've even seen some individuals using bedaquiline as well, which is a new TB drug. I've already talked about the duration, but surgical intervention is really key. And in some circumstances, segmentectomy or lobectomy is really what you need. So what are the research implications? Well, before we go into that, any questions? So what are the research implications? So, I kind of have a three-pronged approach right now for this. Epidemiologic studies here in Central Florida. Pharmacotherapeutic studies, which I'm doing in conjunction with some faculty at UF Lake Nona in Orlando, and also some immunologic studies, which I'd like to get off the ground eventually. And the immunologic studies kind of revolve around the following questions. Is there an innate T cell issue, an adaptive T cell immunity issue, and is there T cell exhaustion, which is, we see a lot in cancer therapy, blocking off some markers, but it could be important in some of these chronic infections like Mycobacterium abscessus. So epidemiology. So we talked about Becky Prevost's study, but there was another study out of Miami in 2018 that showed that they had 108 patients. Most were pulmonary infections. There was more of a female to male predominant, even though it was equal. There were, most of the studies have shown that more women get this than men that are in that don't have an intrinsic pulmonary problem. But they had almost 16% inpatient mortality, which I found interesting. Sensitivity broadly was to clarithromycin, amikacin, and tigecycline. Resistant, like I said, to sulfa and fluoroquinolones. They found that as well. Most of the patients who died had, disseminated infection, a prosthetic device. They either had acute kidney injury, a solid organ transplant. They had immune suppression medications, or they had macrolide resistance, which is doom. And of course, this could go along with other things, but IV amikacin administration. So we have a study that was complete, and we're trying to publish the paper now with my good friend Jamie Morano and some folks down at Tampa General who've been really helpful with this. And so it was a joint effort through USF. Of course, when I was at UF, Tampa General, some people here at the VA, and we're going to do this at the VA as well, and also the Department of Health. And so we looked at all positive cultures, both pulmonary and tegumental infections for all NTMs. And interestingly enough, Mycobacterium abscessus was the #1 infectious agent in this. And we got susceptibilities, and we have some of that data. I'll wait for you to get the publication. Hopefully it comes out eventually. But we looked at documenting some of the predisposing health factors, whether that be an immunocompromising condition, pulmonary disease, HIV. But we also interestingly did some geographic locations and did a GIS map. And this kind of told us where some of these infections could be. Did people live around certain water sources? That was part of our hypothesis. And this gave us a large catchment of cases. So we're going to do this. So that should be coming out shortly. And we're going to do a similar study. One of the fellows, Dr. Zahina Cornelius, is going to help me do it at the VA. So let's briefly talk about therapeutics. So this is, again, it's a real problem, right? Because one of the major problems is that well, there's several, but the main problem is that patients really cannot tolerate these drugs. And usually there's 3 or more drugs, and there's at least 1 to 2 parenteral drugs. And so this really impacts people's lives, and they usually have to be on these drugs, like I said, for 4, 6, 12 or more months. So I did a study with the people at UF Lake Nona, including George Drusano, who leads the group over there. And we looked at several different, this was a quality improvement study. So we looked at several different isolates of abscessus that I had collected with different resistance markers, and looked at their sensitivity profile in toto. And these are the results here. And you can see that for the most part, a lot of them, half of them were wild type and did not have a lot of resistance factors. Only 1 had macrolide resistance outright, which is indicative of the RRL positive. Aminoglycoside resistance phenotype or a discordance, and you can see that in the lavender. Orange showed fluoroquinolone resistance. And then we used 1 green, which the one in green was used in our linezolid study, which had an MIC of 16, which is on the cusp of being resistant. So how do we do it? We use something called a hollow fiber model, and George and Arnold Louis' group over there at UF Lake Nona, they invented this, and this is a super cool way to study. So what they do is that the organism is basically in this cartridge, and there's media that's continuously going in and out of this, and is pumped in and out, and the waste is collected and eliminated. But there's a drug that's administered, and you can administer the drug on different schedules, whether that be a standard schedule, an extended release kind of schedule, or a continuous infusion. And so, extended infusion and a continuous infusion. And this basically shows the organism can't leave, and you can see in real time what the concentration of drug is there as relative to the growth curves and the regression of growth curves based on a log scale. And so what we did was we looked at linezolid doing this. And so we had different treatment arms. So we wanted to see if, as it's known, you really shouldn't be treating mycobacteria with a single agent, because of the fact that there's numerous resistant mechanisms, as well as numerous ways for the organism to, whether it's in their smooth or rough phenotype, to not be able to process the drugs, and the drugs become ineffective then, right? Because they're in this non-persister phenotype. So we had different control arms. Treatment arms. One control, one where we gave linezolid 600 milligrams once a day, 300 twice a day, 600 once a day, which is the dose used in Mycobacterium tuberculosis complex, by the way. 1,200 milligrams 24. And also we did 600 milligrams continuous infusion, as well as 1,200 milligrams continuous infusion. Target inoculum was around 100,000 CFUs, but actually it was close to about 5,000. And of course, we used this SHAN 6 strain, Mycobacterium abscessus, subspecies abscessus. And given the MIC of the linezolid, we dosed it at 2 milligrams per milliliter, and the media we used was a standard media used for mycobacteria. So this is the data, and this is the total population over a week. And the reason we stopped it after a week was because after a week, everything became resistant. But if you notice, the 600 milligrams continuous infusion, once a day rather, gave us best inversed U plot, which shows that there was the least amount of logs of CFUs of the organism that were around despite this. However, just like everything else, after a week, the resistance clones were singled out and they ended up growing out. However, if you notice, if you looked at lower doses or ones that were every 12 hours, really didn't help. And then eventually they all kind of joined the control group. And at 7 days, it didn't matter what drugs we were using, the resistance clones were there. So what's the take-home message from this? So, Mycobacterium abscessus can be grown, of course, in hollow fiber system, which is a really cool thing, which we already knew it's already been done for TB, but this is the first time it's been done. And then if you notice here, there was an exponential growth. Notice this rapid resurgence of resistance, this hypermutator phenotype, which you can see in Pseudomonas aeruginosa and other organisms. Linazolid imposed some microbiologic effect, really, but again, the amplification arms affected, really didn't do much, and at the end, were just as bad as the non-treated control. So the emergence resistance was pretty high with monotherapy, which is confirmed. And so optimal combination of chemotherapy is really what we need, and George's group is going to start looking at that shortly. So what are the next steps? So, do we want to do this on a broth, agar? Is it better to do that? And they're developing a murine model as well. And then, hollow fiber, continue to do with that. And does the subspecies really matter? And I think that that's something that George's group is trying to do, and they're doing an R01 proposal for that now. So finally, let's talk about the immunology of Mycobacterium abscessus. So less is known. There's studies out of South Korea and France that have kind of gone into this, but we really don't know what's happening. Is it going from a commensal to a pathogen? And is there some kind of T cell imbalance, balance or imbalance that's occurring, that's allowing this to transpire? So Diane Ordway at Colorado State has some murine models with a knockout mouse for this, demonstrating an interferon gamma, deficient mouse, and she's published some things on this. However, we really haven't elucidated a mechanism. So if you remember, when we discussed the pathophysiology, I wanted you to notice that there were some T cells that were not really discussed there, but I think are really important in controlling the infection. So as a review for the fellows, an innate immune system, you have macrophages, mast cells, natural killer cells, other types of granulocytes, and dendritic cells, right? And the adaptive immune system is really composed of lymphocytes, including B cells, T cells, and T cells can be broken up into different Th cells or cytotoxic T cells. But there's also some in the middle that do both, whether they be mate T cells, gamma delta T cells, or natural killer Ts. They could be important in controlling infections such as Mycobacterium abscessus. So we talk about a commensal to a pathogen. So what about the innate T cells? Well, we know that in some infections, these T cells affect commensals, which you have, in normal flora, and they prime the local immunity. So basically, they're sparring partners for these innate T cells. And so the innate T cells don't have these organisms that are normally in the respiratory tract around. If that local microbiota is depleted or changes, then the innate T cells aren't really primed. And this was demonstrated in a PLOS One paper from 2018. And then they became these organisms like mycobacteria can become pathogens. And so again, this could be due to structural changes in the lung or immune depletion or other things. But that's a hypothesis. The other thing that's interesting are looking at local versus systemic T cell exhaustion markers, like PD-1, which is, there's some PD-1 inhibitors that are used in cancer therapy, TIM-3 and LAG-3, which are, also could be implicated. And then in malaria, there's a similar phenomenon with TIM-3, where idea kind of came, and how, you know, the expression of this gene product on gamma delta T cells causes co-stimulation of 12 and 18. And so if there's exhaustion and these markers are there, then from there the organisms really are not kept in check by these T cells. And so this is from 2010, but it's kind of tells you what's going on. That, you know, not natural killer T cells, not natural killer cells, but natural killer T cells are important in clearing both malaria parasites in the hepatocytes and also in you know, in the spleen and liver from, you know, the macrophage lineage cells. And the same thing also happens in HIV as well. And so why couldn't this occur in other you know, in other infections? So in my study from 2017 that we did with one of my postdocs, Jason Lehman, who's now back in San Diego, we did this for malaria, and you can see that in patients who were asymptomatic versus symptomatic, that there are certain changes in certain cell types, whether that be you know, some regulatory T cells, which are indicative in the bottom right in F, and general CD4 T cells, and also, and you know, these natural killer like T cells as well. And so they can be primed, especially in gamma deltas, from doing different things, whether that be an innate boost early on in the infection, an adaptive boost based on, you know, dendritic cells and other types of antigen presenting cells, as well as some problems when there's damage to the epithelium, or you know, in this case, and other types of cytokines that are generated that activate these gamma delta T cells and other types of innate T cells. And so this is, and I apologize for not putting the where this is from originally, but this cartoon kind of illustrates that, and that there are different mechanisms for clearing different pathogens that are imperative for these innate T cells. And you can see that's Klebsiella pneumoniae, Chlamydophila or chlamydia, Mycobacterium tuberculosis, you know, Streptococcus pneumoniae, and even B. pertussis can all be help regulated through an IL-17 pathway from gamma delta T cells. Now, gamma delta T cells and innate T cells don't really work like regular T cells. They don't really use proteins and peptides as a way to identify certain pathogens. They usually do it by carbohydrates and complex carbohydrates and lipids. And so that's a different way of recognizing this. And so it's imperative that in studies like this that we not look at just the proteins, but also look at the other components of the organism. So IL-17 could be really impactful in figuring out what's going on with creating, you know, a granuloma or controlling the infection. So the aims of future grants that I want to do is to look at the host response and looking at patient cohorts, getting, you know, peripheral blood mononuclear cells, and eventually maybe even pulmonary cells, and look at the recalled T cell immune response, looking at whole cell lysate of the organism. And this will also include gamma delta T cells, natural killer T cells, and other things, right? So, and that'll be, we'll use flow cytometry and multiplex cytokine, chemokine kind of studies using bead assays. And also, we'll also look at some of these, you know, some of these apoptotic markers for different cells like PD1, TIM3, and LAG3. Maybe even do some HLA typing. The other thing I might want to do is look at antigen detection. And so in 2017, there was a paper that kind of came out that looked at the 560 membrane-bound proteins in Mycobacterium abscessus. And so George Blanc and I from USF actually collaborated and came up with a list of different proteins on the outer surface, and we want to look at adaptive T cell markers for that. So you know, this will be done with MHC1 and MHC2 design epitopes for alpha beta T cells and see what happens. If we have to use tetramers, probably it's the way to go, but we'll see what happens. And again, using flow cytometry, multiplex chemokine and cytokines are really important. So in closing, we'll kind of talk about some of these future ideas. So the immunology of abscessus, looking at, again, obtaining mononuclear cells from the BAL of patients as well. So getting actually cells that are in the lung to look at abscesses. This is also done in TB previously to see what the recall response to the organism is. And then depletion of certain subsets of the gamma delta T cells, looking at these populations and other innate T cells on the effect of polyfunctionality. And then seeing if there's these depletions are important in the different subsets. And then what are their protective responses? How do we, looking at the study methods that I kind of showed there, is there a way to kind of capitalize on that and see what's really going on? And then finally, looking at RNA-seq or mass spec to some of these, some of these binding partners, some of these peptide sequences in alpha beta T cells and what they recognize versus healthy and infected, donors. Because why is it not an infection in patients who don't have one of those conditions I mentioned earlier versus those who do? And then again, finally looking at, this could be done with RNA-seq, looking at the transcriptional machinery to look at certain regulation of precursors of, interferon gamma, IL-17, maybe some of their precursors like IL-22, and infection of certain antigen-specific cells from these mononuclear cells. So what are the take-home points from this? I talked a lot about a lot of research, some kind of updates with guidelines, even though I don't like guidelines from the American Thoracic Society. Abscessus is a rapidly growing mycobacteria with a high prevalence in Florida. We know that. We know that this is being documented slowly but surely, and even by our group here at USF. So again, pulmonary integumental cases, but again, you see rarely disseminated cases, but I can tell you that some patients that I've seen at Moffitt, and even a couple that I've diagnosed here at the VA and previously at UF, looked at disseminated, and I got AFB blood culture. So if you have a patient who you're suspecting could have a mycobacterial infection, get an AFB blood culture. There's a possibility that it could turn positive. And we've captured some of these infections actually recently at Moffitt, and are really trying to treat through some of these complicated patients. So there's different resistance mechanisms, as I mentioned, multiple combinations. My advice, and people like Kevin Fennelly and Kevin Winthrop at OHSU and Chuck Daly and those guys at National Jewish, is not to really do monotherapy, even though it is done, because of the different resistance mechanisms that can occur. So I would just advise cautions with that. But that PK/PD studies are imperative. We need this so we can really lock down what are the really good therapeutics that we can use. I can tell you that there's even some hinting of using an oral carbapenem out there for this, and other novel drugs that are being developed that I could be involved in the next grant cycle. And then of course the immunological conundrum. So description of immune responses. We need to know what they are. Even though there's some data out there, it really doesn't help us. And so what are the innate T cell roles? I really do think that and the T cell exhaustion is critical. Eventually a T cell T-spot test like like we have over TB or an IGRA would be nice. And I think that using an interferon gamma, but also IL-17 ratio could be important, as I think that IL-17, a reduction of IL-17 production is a poor marker for how well, for how patients will do moving forward. So I have a lot of acknowledgements, people at UF and that work with me or for me or have mentored me over the past. People here, as you can see there, Jamie and Doug Holt and Beata and Jose and of course John Tony and everybody else there. I don't know why I have Jose there twice. Kami and Sandy and of course Joe Lozama, who brought me here, who I've known for many, many, many years.